All right, now I think you have audio. Is the audio there? Can you all hear me? Hi, guys. Good evening. Good evening. Welcome to the second part of surgery sprint. All right, now I think you have audio. Is you? All right, so let's kickstart. Let's roll down to another important session in surgery. All right. So yesterday we had quite a bit of discussion. I'll be continuing from where we left out. We'll start with the basic suturing rules. We'll see what is the basic objective, and then move from there onwards. Okay. Guys are scrolling in. I've been asked to wait for a couple of seconds. I will be waiting for 2 more minutes, and then we'll start. All right, so let's kickstart. We were talking about sutures. Let's take a quick recap on sutures. What are important, what are not important. Whenever we talk about sutures, one of the most important aspects is its basic classification. We all know the basic classification that sutures can be divided into two categories. One we call it as absorbable sutures, and another one are your non-absorbable sutures. Your absorbable sutures. One second. One is your absorbable sutures, another is non-absorbable sutures. So when we talk about this absorptive capacity, right, we're talking about the absorption, we're talking about how is the suture getting disintegrated by a simple fact that it is getting disintegrated by your enzymatic digestion, right? That is because of the enzymatic digestion of the suture material. Now, when you talk about absorbable suture material, any suture classification is further classified based upon where it is derived from. We all know it. We have the natural sutures as well as the synthetic sutures, right? Now, what are the examples of the natural sutures? The most, I would say, the basic example of a natural suture is what we call it as the catgut suture material. Another one that we have, it is called as the chromic catgut. Another one is what we call it as chromic catgut suture material, right? Now, when we say catgut suture material, one of the most primary question or basic question that they ask you is where is it derived from? I will take a quick feedback if you can tell me from where it is derived from. Manoj, the angle between any needle and the skin during an entry point will be 90. Varys needle is also the angle between the skin and the needle is 90, but the needle in the body is 45 degrees, right? That is very important because you will pull the skin up, put the Varys needle in. So the angle between the skin and the needle is 90, but the body is here. So the between the body and the Varys needle is 45 degrees, right? Now, where is the catgut suture material derived from? It is derived from, as majority of your thinking correct, it is the submucosa of sheep's intestine, right? Now, one of very basic question is, if it is derived from the sheep's intestine, why are we calling it as catgut? We should call it as sheep gut. No, we should call it as sheep gut, not catgut. Then why are we calling it as catgut? A simple concept here. Here the cat that you're thinking is not the cat actually that is pertaining to, right? It is not the cat that you think it is cat. It is cat means cattle. Cattle means grass grazing animals. So you can take it from any grass grazing animal, submucosa. Now, logically thinking, no, why would have, why are you taking from sheep? Or why not you taking from cattle? Or why are you not taking from pig? It's a simple concept. Certain countries in the world won't accept cow and other ones won't accept pig. So who is the easy one to take across? That is sheep. That is why sheep is called as what in Hindi? Bakra. No, yaar, bakra is acceptable everywhere. So bakra hi hua na. That is why you take it from the sheep per se, right? It is the submucosa, not the mucosa. The strongest layer of the GIT is the submucosa. Now the problem is when you are using the catgut suture material, it is going to get absorbed in 7 to 10 days. To increase its absorbability, we are using chromic catgut. The average time period for absorbing the chromic catgut is going to be 90 days. It is going to be 90 days. On the other hand, when you're talking about the synthetic catgut, right, or sorry, the synthetic absorbable suture materials, these are called or named as Vicryl, one of the most common one. Then you have the polyglyconate. We have the polyglyconate. Then you have polydexon, that is PDS as the suture material. Then you have dexon, which is another suture material, and a monomer of Vicryl that is called as the monocryl. Vicryl, on the other hand, is also known as the polygalactin. It is also known as polygalactin. The average absorbable lifespan for this is going to be 60 to 90 days, right? Polyglyconate is 180 days. PDS is also going to be 180 days. Dexon is also called as polyglycolic acid. It is also called as the polyglycolic acid, which is going to be between 60 to 90 days. Monocryl, it is your polyglycoprone. It is your polyglycoprone, and the polyglycoprone will be between 90 to 120 days. It is going to be 90 to 120 days, right? So that is why we are going to use the synthetic ones, because they are easily absorbable or they are readily available. Also, you have in the low tissue reaction as well. So Vicryl, you have polyglyconate, you have PDS, you have dexon, you have monocryl. Dexon is associated with the least tissue reaction. It is associated with least tissue reaction, whereas catgut, it is associated with maximum tissue reaction. So we want anything which is biologically inert. If it is reacting, it becomes very difficult for us to use it in a normal sense, right? So this is the basic division in terms of absorbable. Now the one that is non-absorbable, we say it stays for life. When you start your surgery residency, we'll tell you a very common quote that proline stays for life. That means it is going to stay as long as you stay. So non-absorbable is same. We have the naturally non-absorbable suture material and the synthetic non-absorbable suture material, right? So the examples of naturally available non-absorbable suture material, one of the most common one that we have, it is silk. Then you have cotton, and a variant of it is going to be linen, right? Silk, cotton and linen, called as the silk, cotton and linen, are the natural non-absorbable suture material. When you talk about synthetic non-absorbable suture material, one of the famous one that you have, it is your proline, also called as polypropylene, also referred to as the polypropylene. Then you have the polyester, right? Another suture material that you have, it is the polyester. Then you have nylon, which is commonly used. A polymer of it, it is the ethylene that is used, and obviously the stainless steel and the stainless steel. All these are non-absorbable synthetic suture material, right? So this is the basic of this. In all this, what is the important aspect for the exam? The things that you want to remember for the exam is the absorbable periods of all the suture materials, right? So these are your exam questions. So I had to emphasize on these numbers. Yes, they are tedious. Yes, they are difficult, but they are absolutely important. They are absolutely important, and these are your suture materials that we're going to use across, right? Now you have something called a suturing rule. Now, in order to understand the suturing rule, the first thing, you have the following questions. What is the length of the suture material required to suture any wound, especially your abdominal wound? You have to measure the length of the wound. Let's say if the length of the wound is L centimeters, the length of the suture material required to suture that particular wound will be 4 times the length of the wound, that is 4L centimeters. It is going to be 4L centimeters, right? Now, let's say we are taking the depth of the wound as X centimeters, right? This X defines the depth of the wound, and that could be your 1 millimeter, 5 millimeter, 1 centimeter, anything is possible. Now, why this is important is the depth of the wound determines from where you want to take the prick. Now, let's say this is the needle, right? Let's say this is the needle that you are pricking into the skin. The angle between the needle and the skin at the entry point is 90 degrees. And this was your recent exam question, right? Now, as you go in, the distance from where you're going to prick, that is from the edge of the skin, from where, how far will you go away from the edge, will be same as the depth of the wound. Whatever is the depth, whatever is the distance of depth, or whatever is the measurement of the depth, the same amount you will move away from the skin, and then you will go into the skin and you come out from the other end. Where will you come out? Exactly the same length as the depth of the wound. So X determines the depth, and that determines from where is the entry and the exit point. Distance between the two sutures, let's say this is one suture, this is suture number 2. Distance between two sutures will be twice the depth of the wound. As simple as that, right? So remember, the length required to suture a suture, the length required of a suture material to suture a wound will be 4 times the length of the wound. The entry and the exit is determined by the depth of the wound. Distance between two sutures are going to be twice the depth of the wound. It is going to be twice the depth of the wound. The angle between the needle and the skin is 90 degrees. Distance between the two sutures is twice the depth of the wound. What is the length of the suture ear? Now, what is the suture ear is when you have a suture, right? This is the knot, and then you, after putting a knot, you cut. Whatever which is left behind, this is what we call it as the suture ear. The minimum length of the suture ear should be 1 to 2 millimeters. Otherwise, the knot will slip away. Otherwise, the knot will slip away. So, hence, you have to make sure the length of the suture material stays between 1 to 2 millimeters per se. Right? Now, what are the various techniques of suturing? You can see you started the suture from here and then you went in a continuous manner, and this is what we call it as a continuous running sutures. This is what we call it as the continuous running suture, right? On the other hand, you will notice that there is one entry point here, and then you're putting a knot and exiting on the other end, right? So entry and exit, and there is no continuity, and this is what we call it as simple interrupted sutures. They are simple interrupted sutures. These are simple interrupted sutures, right? Now, on the other hand, when you look at the image number 3, something very peculiar that you have to notice, that there are 2 pricks on one end, 2 pricks on the other end, then there is a knot, right? Twice you have pricked, another time you have pricked twice, and then you have knotted. So 2 times here, 2 times here, and then a knot. 2 times here, 2 times here, and then a knot. 2 times here, 2 times here, and then a knot. Now, this is not how it usually presents, but this is the easy way to understand. But what type of suture it is? Now, in order to understand, I hope everybody knows that this is a mattress suture. But the problem is it a vertical or a horizontal mattress? When you look at this image, it looks horizontal, but it is not. Why? You have to see the orientation of the wound and the orientation of the suture. If they are perpendicular to each other, this is what we call it as the vertical mattress sutures. On the other hand, you see this is the orientation of the wound and this is the orientation of the suture material. This is what we call it as horizontal mattress. This is what we call it as the horizontal mattress sutures, right? Then this suture that you're seeing in front of you, you're not coming onto the surface of the skin, right? That is, you can look across it. We're going into the skin and then we are suturing here. And this is run between the dermo-epidermo junction of the skin. And this is what we call it as subcuticular suture. Now, this is considered to be best for cosmetic outcome. This is best for the cosmetic outcome. So, hence, this is considered to be the best one. Okay. Clear? Okay. Uh, the new thing that I've learned on YouTube is how to block somebody who is irritating. Thank you. Now, so these are the various suturing techniques that you need to understand and get in terms of your exam. Another one is knotting, very very popular. When you look across here, now when you look across here, you can see this is a green thread, this is a red thread, and they're looped only once. And this is what we call it as half hitch, right? This is what we call it as half hitch, or also referred to as a single loop. Remember, this is an unstable knot. Obviously, no. If you put a finger under this, right? You put a finger under this, you pull it, right? As you pull it, the entire knot will untie, right? The entire knot is going to untie. Guys, the PDF will be available. It will be posted on the groups. It will be given on our, I think there is a Facebook channel or a group as well. We'll put all these PDFs down there. Okay. Okay. So now when you look across here, this is what we call it as the granny's knot. This is what we call it as the granny's knot, right? Now, granny's knot is an example of an unstable knot. It is a knot that you put on your sweater. One thread comes out, you pull, the entire sweater will go off, right? Now, on the other hand, guys, if you have attended a series somewhere else or you have done a session before, if you are confident enough, you can use the time to read something else or use your time for a better, I would say, revision. If you have certain doubts and concepts, you can always listen to this lecture, and this is anyhow will be available in the YouTube as well, so you can come back and revise whenever required, right? So don't worry about it. Now, this is what we call it as the square knot. This is what we call it as the square knot. This is also what we call it as the reef knot, right? Now, the square knot or the reef knot is also considered to be an absolutely stable knot. This is an example of an absolutely stable knot. Now, how do you identify the difference between the granny's knot and the reef knot or the square knot? They look almost the same, right? But this is where the surgeon's vision or eye is required. Now, I want you to identify this red thread. And the one that is shown in the video, this is like a black thread. Now, I want you to identify the red thread is under the black thread here. And here the red thread is over the black thread, right? You can see one thread is going under the loop, another thread is going over the loop. If they are going one above and one below, this is what we call it as a granny's knot. In the square knot or the reef knot, you can see this red thread is going under the loop. Here also the red thread is going under the loop. On the other hand, if you see, you will identify that here the black thread is going over the loop. Here also the black thread is going over the loop. So either the thread has to go under the loop or over the loop, both the threads, right? So if you look at one particular end and if you examine, you have to see that in one particular end, if both the threads are going under the loop or over the loop. If they're going under the loop, that is considered to be, if they're following the same direction, under or over, that is reef or square. If one is going above, one is going below, that is what we call it as the granny's knot. Clear? Very, very important. Clear? So, now on the other hand, when you look across here, this is what we call it as the surgeon's knot. Surgeon's knot is the most stable knot. It is the most stable knot. It has got two loops on the base. Here you have two loops and then you have one loop on top, right? One single loop on top. There's a small, I would say, correction that has to be made. This is going to be something like this, right? You have to remember that it has to have a proper squaring, same as your square knot. right? So this is in fact the most stable knot that you are having across. This is the most stable knot that you have, right? So these are the knotting techniques that are going to be absolutely important. Clear, guys? Very, very important in terms of your exam prospect. Clear? Okay. Can we move on? Okay. So talk about the suture removal period. When would you like to remove if you have put a suture on the face? Remember, on the face it is between 3 to 5 days. It is between 3 to 5 days. On the scalp, it is going to be 7 to 10 days. On the arms, it is 7 to 10 days. On the trunk, it is going to be 10 to 14 days. Legs is going to be 10 to 14 days. Hands and feet is going to be 10 to 14 days. Palms and soles is going to be 14 to 21 days. This is the standard data that you have to remember, right? Okay. So this is with respect to suture removal periods. Very, very important. Clear, guys? All right. Now, another very important topic that we have for the exam is going to be the pressure sore, the bed sore, or the decubitus ulcer. Remember, the pressure sore, the bed sore and the decubitus ulcers are the old terms. We don't use it. Now we are using only the pressure sore, right? Now, remember, when you're understanding a pressure sore or the bed sore in simple points, what is the most important criteria? The concept is very simple. Whenever a pressure is exerted, or we call it as if there is a sustained pressure. If there is a sustained pressure, one second, guys. Now, if there is a sustained pressure over a dependent, if there is a sustained pressure over a dependent area of body, if there is a sustained pressure over a dependent area of body and this pressure is greater than the capillary occlusive pressure, if it is greater than the capillary occlusive pressure. Now, this capillary occlusive pressure is a pressure required to occlude the capillary so that the blood flow to that particular area of the skin can be deprived. And normally, the capillary occlusive pressure is anybody. How much is the normal capillary occlusive pressure? If it is more than or equal to 30 millimeters of mercury, and this is your capillary occlusive pressure. Now, whenever there is a sustained pressure, obviously, if it is beyond the capillary occlusive pressure, this will result in tissue hypoxia, and this tissue hypoxia will result in tissue necrosis, and this tissue necrosis will result in ulceration, and this is what we call it as pressure ulcer. As simple as that. What is the most important risk factor? Remember, the most important risk factor is going to be the dependent state, right? So any patient who is having a chronic bedridden status, or any patient who is having a wheelchair bound status, if the patient is chronic bedridden or a wheelchair bound status, or if there is a prolonged immobilization, especially if it is in a post-operative status, or patients who are chronically sick, right? All these are the important risk factors which results in bed sores. Now, what are the most common sites, right? When you talk about the most common sites, you have to think in terms of a very simple status. When the patient is lying down, this is the lying down posture, this is the head, this is the neck, this happens to be the shoulder area, and then this is the limb status that is present, and this is the body that is present. So when you see where is a constant pressure, the constant pressure is there on the occiput. The constant pressure will be in this area. There are three sites in this area. One, I would say there will be sacrum. One, there will be sacrum. Another one, there will be ischium. and another one there'll be greater trochanter. Then you could see a constant pressure is on the heel, and obviously some amount of pressure if the leg is spraying across on the malleolus, right? Of all these sites. Okay, so from all these sites, which is the most common site? The most common site for the pressure ulcer is going to be ischium. The most common site is going to be ischium. Okay. Now, obviously followed by your sacrum and the greater trochanter, which is in that area, which are more commonly exposed and damaged, right? So these are the sites where you will develop pressure ulcer. Patients usually develop pressure ulcer. Looking at the pressure ulcer, we have different grades, which is given by the National Pressure Advisory Board, which tells you that what are the different types of pressure ulcers that you have, right? When you look across here, in the image number 1, okay, right. In the image number 1, we call it as grade 1 pressure ulcer on the basis of this, right? What is this? This is a non-blanching erythema. If there is development of erythema which does not blanch away on pressure, it is grade 1. Grade 2, you can see some amount of skin is being peeled off, and this is what we call it as partial thickness. There is partial thickness skin loss. It's a partial thickness skin loss. Then you see the subcutaneous fat is exposed. This is what we call it as the full thickness skin loss. This is what we call it as full thickness skin loss. And here you can see the underlying structure is involved. The underlying structure can be a tendon, a vessel, a bone, a nerve, anything that is there. If it is involved, we call it as grade 4. That is involvement. If there is involvement of underlying structures. If there is involvement of an underlying structure, this is what we call it as grade 4, right? Shoulder blades are less affected on the pressure ulcers. Yes, they can also be, but then among these are the ones that we have discussed are more common. There is another variant that is added. We call it as US, that is stands for unstageable. We call it as unstageable if an ulcer is covered in slough or necrosis, because the true depth of the ulcer cannot be assessed while if there is presence of slough or necrosis until you debride the ulcer, right? So that is an important aspect that you need to consider. How would you like to manage? We call it as grade 1 and grade 2 as the low grade ulcers. For these, the management is very simple. It is going to be a conservative management. Now, in the conservative management, the first advice that we are going to give our patients is going to be frequent change in position. This is what we call it as the frequent change in position. So, when you say frequent change in position, when you say the frequent change in position, any patient that comes to you will ask you a very simple question, right? When you say frequent change in position, how frequently should I change? Now, the advice for this, you have to see whether the patient is going to be a bedridden patient or if the patient is wheelchair bound. Now, if the patient is bedridden, then I will say every second hourly you have to change the position. If he is a wheelchair bound, in every 10 minutes, I would recommend him to lift himself off the wheelchair from his own hands for 10 seconds, right? So 10 minutes in every 10 seconds is in a wheelchair status and 2 hourly or second hourly in a bedridden patient. Along with frequent change in position, I will ask the patient to get a water or an air bed that will decrease the exertive pressure so that the capillary occlusive pressure cannot be reached. Right? So there's frequent change in position, water or air bed. There is absolute skin care that has to be taken in these areas so that you'll be able to prevent these ulcers from happening. Right? So the grade 1 and grade 2 is simple. Now when it comes down to grade 3 and grade 4, these are advanced. Right? For an advanced ulcers, you have to go with cleaning and debridement of the ulcer. C&D basically means the cleaning and debridement of the ulcer. And you might also need to use VAC. VAC stands for vacuum assisted closure. But the problem is this word is obsolete. We don't use VAC any longer. The VAC is an obsolete term or an old term. The new term that we use, it is called as the negative pressure wound closure system, NPWCS. It stands for negative pressure wound closure system. It is your negative pressure wound closure system. Here the pressure exerted is going to be minus 125 millimeters of mercury, and that too on the intermittent basis. The advantage of VAC is you don't need to teach or change on a daily basis, right? You can put it the VAC and leave it for 3 or 4 days and then resume it or rechange it on the second part, right? Another advantage is, like in a regular dressing, you have to change as either twice a day or at least once a day. In VAC, I can leave it for 3 to 4 days and then put another VAC, and usually in 2 or 3 settings, the wound do respond very well, right? Along with this, obviously, the wound care, that is dressings and antibiotics. With this, all the conservative protocol that we have done, and then if required you have to take the patient for skin grafting. If the defect is more, then you have to consider for flap reconstruction. If the wound is deep enough, you have to go either for skin grafting or you need to go with for flap reconstruction So this is in a nutshell about your pressure ulcers. Very, very important topic from our recent exam pattern. So do keep in that form, right? Chalo. Another important topic that you'll come across is going to be burns. So burns are very, very important, right? Now, when you say in terms of burns, there are two questions that are going to ask you. What is the most common method of burn wound assessment, and which is considered to be as the best method to assess the burn wound area? The most common is what we call it as the Wallace rule, also called as rule of 9. The best method, it is going to be the Lund and the Broders chart. It is going to be Lund and the Broders chart. Clear? Clear? Chalo. Now, when you talk about the Wallace rule, the rule of 9, everybody knows it. The head and neck in the adult is going to be 9%. The anterior trunk is 18%. The posterior trunk is going to be 18%, right? Head and neck 9. The anterior posterior trunk is going to be 18%. The upper limb is going to be 9%. The perineum is going to be 1%. The lower limbs on the either side is going to be 18%. Anterior trunk 18%. Posterior trunk is going to be 18%. The head and neck together is going to be 9%. In total, it will be 100%. What is there in children is the head and neck remains at 18%. The anterior trunk is 18, posterior trunk is 18. The hands are 9. There is no perineum, but the lower limb exists at 14%. If you take palm alone in both adult and child, the palm will comprise of 1% alone, right? Now, when you talk about the burns, one of the most commonly asked questions is how do you assess the burn wound depth, right? How do you tell me that is it a first degree burn, a second degree superficial burn, a second degree deep burn, a third degree burn, or a fourth degree burn? On what basis are you going to tell me that this is the status of the burn? Now remember, in the first degree burn, it is only the epidermis that is going to be involved. It is only the epidermis that is going to be burnt across. In the first degree, it is going to be epidermis alone, right? Now, if the burn is more or it is significant, it is going to sink down and it is going to involve the papillary dermis. If it is involving the papillary dermis, is secondary superficial. If it is involving the reticular dermis, it is secondary deep. If it is involving the full thickness of the skin, it is third degree. If it is involving the underlying structure, if it is involving the underlying structure, the subcutaneous fat, the muscle, the nerves, the tendons, the vessels, anything, then it will become the 4th-degree burn. Now, how do you see? All these are microscopically understandable. It is not very easy to differentiate between epidermis and dermis and when we talk about papillary and reticular dermis. So, how do you pick up clinically? The most important component is pain. Remember, the 1st-degree burns are extremely painful. The 2nd-degree superficial is extremely painful. There is no pain thereafter because there is no skin left. But remember, I'm saying there is no pain in secondary deep, but there is presence of pin prick sensation. You touch on the burn wound, there is no pain. But when you take a pin and prick it, you will have that stingy feel that the patient will also feel across, right? The blisters may or may not be present. The blisters are present in secondary superficial, secondary deep may or may not. From here onwards, there is no blisters. So blisters are characteristic of secondary superficial. The color here, when you see a patient of burn, it is going to be in terms of 1st-degree. It will be bright red, or I can say rather bright red. We'll say there's presence of erythema that you can notice here. Here it will be seen as bright red color. But the most characteristic you'll see in secondary deep, you will have the mottled pink appearance of the skin or the pale waxy white in appearance. Either it is going to be mottled pink or waxy white in appearance. Here it is going to have a leathery appearance, like a leathered skin, and here it is going to be charred, like a charcoal that is burnt, right? Now remember, these wounds will heal, they will not heal. You will require something as an intervention to heal them across. There is no scar here, the scar will be present here. The scar will definitely be formed in these two. The eschars are usually not seen here. Eschar may or may not be present here, but eschars will be seen in these burns which are present. So this is how you'll differentiate if you're looking at the 1st-degree, the 2nd-degree superficial, 2nd-degree deep, 3rd-degree or the 4th-degree burn. This table will let you understand, remember and recall all the important topic points in your burn wounds, right? Now, one of the majorly asked questions is, how do you resuscitate a patient of burn? And the resuscitation is usually done with crystalloids, right? Remember, the crystalloid that is used is ringer lactate, and this is considered to be as the fluid of choice. This is considered to be as the fluid of choice. Now, for two formulas, you have the Parkland and the ATLS. I am going to tell you the Parkland is obsolete. We are not using it any longer, which is 4 ml per kg per percentage of total body surface area burnt. Now we use ATLS. Now ATLS says very simple. We will start resuscitating. In a 1st-degree burn, oral fluids are more than important. It is a 2nd-degree burn that you need to understand. If it is a 2nd-degree or a 3rd-degree burn, and if the patient is an adult, then it is going to be 2 ml per kg per percentage of total body surface area that is burnt. If it is a child, then we will go with 3 ml per kg per percentage of total body surface area burnt that is going to be used. If it is a 4th-degree burn or if it is an electric burn, irrespective of adult or child, I am going to use it for 4 ml per kg. Sorry guys. Per percentage of total body surface area that is burnt. Right? So this is what we are going to follow for the fluid resuscitation, and these are your ATLS formulas, right? Now, how would you administer these fluids are very important. Remember, whatever the burn fluid that you have calculated, the entire the entire burn fluid must be administered, or it must be given within 24 hours of burn. So you have to calculate and administer the entire one within the 24 hours of the burn. For example, I have a 70 kilogram patient with 4th-degree burns, right? How much will be the fluid that you are going to use it? It is going to be 4 ml per kg per person. Let's say 30% of the total body surface area is burnt. So it is going to be 30, which will give rise to 8,400 ml. right? This is the fluid that you have to give across. See, if a child, when you talk about child, that is in terms of children, especially in the neonatal age, dextrose can be added. Now, whatever fluid that you have calculated, that is 8,400 ml. I am going to split them into two halves, right? The 4,200 ml as the first half and the 4,200 ml as the second half. Now, when you have the 4,200 ml as the first half, this has to be given as a fast IV within 8 hours, right? So within 8 hours, you have to finish the 4,200 ml, and the next one, this has to be given as slow IV within next 16 hours. So within 24 hours, you should be able to finish the entire burn fluid that is given. Now, the bigger question is, what will you do after 24 hours? What are you going to do after 24 hours? What are you going to do? Are you going to sit tight? No. You have to resuscitate. Will you resuscitate the same amount of volume? No. You will cause volume overload, which will result in pulmonary edema. So to prevent this, I am going to go ahead with the maintenance fluid. Right? Now, how do you calculate the maintenance fluid? That is a rule of 4, 2 and 1. What do you mean by this 4 to 1 rule? 4 to 1 rule says for the first 10 kilograms, right? Let's say you have a 70 kilogram patient. I can write the first 10 kilograms, second 10 kilograms, rest of the body weight together it is 70 kilograms. It says for the first 10 kilograms, it is 4 ml per kg. That is going to be 40 ml. For the next 10 kilograms, it is 2 ml per kg. That is going to be 20 ml. For rest of the body weight, it is 1 ml per kg. That is going to be 50 ml. And if I add on together, it is going to be 110 ml. But this is given per hour. This is how you'll go with maintenance fluid. If you don't believe me, go with 60 kilograms. In a 60 kilograms, this will remain 40, this will remain 20. The 40 will become 40, it will become 40. It will become 100 ml per hour, right? So whatever is the body weight, you will split into first 10 kilograms, next 10 kilograms, rest of the body weight. You will say, sir, what if we have a patient who is 15 kilograms? We'll write the first 10 kilograms. We don't have the second 10 kilograms. We have only the 5 kilograms in the second half. The third half is 0. So this remains as 0. This will become 40 ml. This will become 10 ml. No, 5 into 2. This is going to be 10 ml. This will remain as 0. So 10 plus 40 is 50. It will be 50 ml per hour. Right? But if a patient who is under CCF, I will start the patient on diuretics and then titrate the fluid. I will never give volume which can overload or overburden the heart, right? CCF is entirely a different part, right? So that's not our domain for today. Yes, if the patient is under a cardiac failure or if the patient is having a congestive cardiac failure, you should limit fluids. Totally understandable. Clear? So this is how you will go ahead with burn fluid resuscitation. When you talk about the colloids, no. Now the colloids, number one, it should be avoided. It should be avoided in first 24 hours. I will only administer colloid after 24 hours, right? Now, the most commonly used colloid for burn resuscitation is HAS. That is your human albumin solution. It is your human albumin solution. What is the ideal time to administer colloid? That is should be after 24 hours of the burn. What is the formula that we use to calculate the colloids? Is the Muir and Barclay formula. It says 0.5 into weight in kilograms into percentage of total body surface area that is burnt. So if you take our example, 0.5 into 70 kilograms into 30% of the total body surface area that is burnt, that is going to be 1150 ml, right? So 2100 now, yeah, 21. Oh, I think it is 1050 ml. My math is a bit shaky. So it is going to be 1050 ml of colloid that has to be given, right? Now, whatever you have calculated, this is calculated as one portion, right? Now, how do you administer? The protocol for administration is going to be 4th hourly for the first 12 hours. Then it is going to be 6th hourly for the next 12 hours. and then it is going to be 12th hourly thereafter if required, right? So I will be giving 3 portions of, this is what we got as 1 portion. So I'll give 1 portion every 4th hourly for the first 12 hours. Then I'll give 6th hourly for the next 12 hours, and then I'll give 12th hourly if required. This is the protocol for administration of colloids. Clear? Sure. So this is in terms of the fluid management. Now, again, another important question is going to be in terms of the burn wound management. It is going to be the burn wound management. Right now, in terms of burn wound management, we have the agents which are present. 1% you can give silver sulfur diazine, then you have the silver nitrate, then you have mefenide acetate, then you have these, just ignore this, it is the silver sulfur diazine with cerium nitrate. Now remember, the silver sulfur diazine is an excellent agent against pseudomonas and gram negative. It does not have any effect against eschar, and there are no side effects, right? Now, if you talk about silver nitrate, it has got a good effect against pseudomonas, a limited action against gram negative, no effect against, or it cannot penetrate eschar. It will result in blackening of skin. So skin tattooing is a reason, that is why it is not encouraged much, right? Now, when you talk about mefenide acetate has a very little action for the pseudomonas and gram negative, but it is effective. It can penetrate eschar. Problem is, while applying, it will cause immense amount of pain. So it is painful during application, and more importantly, it results in metabolic acidosis, and this is your exam question. Now, because of silver sulfur diazine, it is extremely effective against pseudomonas and gram negative. It can also penetrate eschar, and there are no specific side effects. The most commonly used topical agent in burns is silver sulfur diazine, but the best topical agent is going to be silver sulfur diazine with cerium nitrate. Right? So this is an important aspect, right? So this is how you will manage your burn wounds when encountered. Clear? So now, another important topic that we'll talk about is going to be a vascular surgery. For now, so far, any questions, guys? A quick feedback. So far, any questions? Quick feedback. Quick feedback. All right, so let's roll. Let's continue. We're talking about the vascular disorders. In the vascular surgery, I'll be talking about the chronic arterial occlusion. So 2 best examples for your chronic arterial occlusions. 2 best examples for your chronic arterial occlusions are going to be the Berger's disease and the atherosclerosis. Right? Now, see, somebody is asking, is there a role of IV antibiotics in burns? Remember, as long as there is no proven role or no proven infection, there is no role of antibiotics. If the patient is found to be in sepsis or if there's a wound infection, I will start antibiotics. Otherwise, for the first 24 to 48 hours, there is no role of antibiotics. Now, in terms, see guys, somebody is asking MCQs. I wouldn't mind taking MCQs, right? If you want, we'll do another session only on MCQs, but the objective of doing these sessions is to revise all high yield topics. I've been telling in my sessions before and previously also that when you're talking about preparation, you need to be smart. Rather than looking at a question as a wholesome, it is better to look at as a topic as wholesome, right? I'm talking about all these topics which are being repeated in last 5 years, all right? So my goal is to revise all the important topics that you have been looking across in your last 5 years of your exam, and obviously the high yielding sessions or the topics of, I'll be telling, see, whenever I mark Q, that is a question that is they have asked you in recent exams. Okay? So I'm trying to balance out both. Now, in terms of the topic, the chronic arterial occlusion, the Berger's and the atherosclerosis, The age of presentation for Burgess, all patients of Burgess will present under the age of 40. Atherosclerosis will be over the age of 50. The most important risk factor for Burgess is going to be smoking. These are the smokers. Atherosclerosis, on the other hand, it is the obesity that forms the predominant risk factor. Remember, Burgess do not have a favorite child. Here we say all four limbs are equally involved. They are equally involved. Whereas in atherosclerosis, it is the lower limb that is far more commonly involved when compared to upper limb. In fact, upper limb atherosclerosis is a rare entity. It is going to be a rare entity. The size of the vessels which are usually involved in Burgess are going to be small to medium sized vessels. Atherosclerosis is going to be large to medium sized vessels, right? So when you talk about the involvement, a couple of important things. Let's say if this is the vessel that we're talking about, right? If this is in terms of Burgess and atherosclerosis, Burgess will have a very patchy involvement. You'll see the vessel involved in these manner. Whereas atherosclerosis will have a continuous lesion that you will see. So the pattern of involvement here, these are referred to as skip lesions, and this is where we call it as it is a continuous lesion. It is a continuous lesion. Now the progression of this in terms of Burgess, if you take this as the blood vessel, and if I say this is the proximal end and this is the distal end, the progression of the Burgess is in this direction. That is distal to proximal progression. Distal to a proximal progression, right? On the other hand, one second guys. On the other hand, if you're talking about atherosclerosis, and we mark it as the proximal and the distal end, this is going to be in this particular fashion. That is proximal to distal end. This is going to be proximal to distal end. This is going to be proximal to the distal end, right? Now the structures which are involved sorry guys, a bit of annual today. This laryngitis, running nose. Everybody suffering, so I'm suffering with them. So structures when involved here, you take this as a representation of an artery. An artery will be accompanied by a vein, and a vein will have a nerve that is present. Now in Burgess, there will be a perivascular inflammation. So it will result in involvement of artery, but because of that, there will be involvement of the nerve and the vein as well. So this is going to involve the artery, the nerve and the vein. All these three structures are involved. Here it is the artery alone. Here it is going to be the artery alone, right? So this is the core difference between the Burgess and the atherosclerosis, right? Now, in order to understand the severity of the disease for any chronic vascular disorder, we measure something called as the ankle brachial pressure index, which is called as an ABPI index, right? Now, in terms of normal ABPI index, now what is this ABPI index? How do you measure it? It is the systolic blood pressure at the level of ankle in response or in comparison to the systolic blood pressure at the level of brachial artery, right? So I'll measure the systolic blood pressure at the level of ankle and at the level of brachial artery, and then we'll compare, and then we'll take a ratio of these two. The normal ABPI index is between 1 to 1.3, right? Now, for a calcified blood vessel, the ABPI index will be more than 1.3 because it will become hardened. For an intermittent claudication, now see, there are certain data which are conflicting. We say intermittent claudication can be seen below 0.9, right? But we say it can also, or it can become evident below 0.7, right? We say some amount of vascular compromise seen if the ABP index is less than 0.9, where patient can complain about intermittent claudication, but not very significantly. Significant intermittent claudication is seen below the level of 0.7. Rest pain will be seen below the level of 0.5. Critical limb ischemia, which is called as an impending gangrene, is seen below the level of 0.3. Now, one of the most important aspects is what is this intermittent claudication, right? Now, a lot of students have a bit confusion of understanding what is an intermittent claudication. Now, to understand this, let's say this is the road that the patient is going to talk on a daily basis, right? Or take. Let's say this is our patient who is present at rest. So when you talk to the patient, he says at rest, right? The patient is absolutely asymptomatic. There is no problem at all. So I say at rest, he is smiling. I say, what happens? He says, sir, when I start walking, after walking for a certain amount of distance, right? Now, this is the point where I start feeling pain, and this is the point where the pain starts. So, after walking for a certain amount of distance, this is the point where the pain is going to start, right? So, I ask him a normal question. If pain starts, what do you do? He says, sir, in Hindi, of course. When I ask him कि अगर दर्द होता है तो क्या करते हो, बोलता है सर मर्द को दर्द नहीं होता तो मैं दर्द सह लेता हूँ, चलता रहता हूँ, right? Patient says even after, if the pain starts, he says I don't stop because I'm a guy, right? And I don't feel, I'm a macho, right? So he continues to walk with pain. But after walking a certain distance with pain, he realizes कि मर्द को भी दर्द होता है, right? And this is the point where he says that the pain becomes unbearable and he is going to stop due to pain, and this is where it becomes absolutely difficult. The patient is going to stop due to pain. Now all this has happened because at rest there are collateral circulations because of chronic arterial occlusion, and they will take care of whatever metabolic demand is there at rest. When the patient starts walking, the tissue demand for the oxygen increases, and because of hypoxia, the oxygen demand of the tissue increases and oxygen delivery should also increase simultaneously because the vessel is occluded. That proportion, the ratio in which the oxygen demand should have been supplied, is not being delivered because the vessel is compromised. So demand is more, supply is less, hence become hypoxic. Hypoxia will cause pain, and pain will keep on building if patient continues to walk. Now when I say when you stop, what do? He says, sir, I find a nice tree, right? I will find a nice tree right on the roadside, right? I will go sit under this tree, right? Now once I sit under this tree, because the pain becomes so unbearable, I go rest under the tree. I reach out to my pocket and I take my best friend out, and then I light it up, right? I take the best friend out and I just light him across, and I say, what do you feel? He says, while doing this, I feel happy. The pain disappears. He says, while smoking, the pain disappears. This idiot does not know that it is not the smoking that is decreasing the pain. At rest, obviously the tissue demand for oxygen decreases, pain decreases, and he improves. And this cycle will continue to happen. So as he continues to walk, after a certain distance, he'll continue to have pain. It decreases, it increases, increase. It continues to happen. And this on and off mechanism of pain is what we call it as intermittent claudication, very characteristic of chronic arterial occlusion, right? So our patient at rest, he's fine. After walking for a certain amount of distance, the pain starts. He continues to walk, the pain becomes unbearable. Now because of this, he rests. After he rests, the pain decreases, and this is what we call it as intermittent claudication. Now the biggest question is, what is claudication distance? Remember, it is the amount of distance. When we say the claudication distance, it is the amount of distance a patient can cover before taking rest due to pain. Now this is what we call it as the claudication distance. Now what is this claudication distance? It is the amount of distance. It is the amount of distance a patient can walk. A patient can walk before taking rest due to pain. Why I'm telling you very significantly about this, because claudication distance, which can be abbreviated as CD, the claudication distance is inversely proportional to the disease severity. The claudication distance is inversely proportional to disease severity. That means if the claudication distance is longer, the severity of disease is less. Obviously, no. If a patient is able to walk for 500 meters and then resting, another patient is walking for 10 meters and resting, for a 500-meter claudication distance, obviously the disease severity is less. But a patient is only able to walk 10 meters, the severity of disease is much, much more higher. So I will say it is of more severe form. Clear? So this is about your claudication distance. This is about the claudication distance. All right. So now, on the other hand, how would you like to manage? Okay. All right. Now, when you talk about the management in terms of atherosclerosis per se, Burgess May will give analgesia. It's a limiting disease. If there's a gangrene, we'll go with amputation. Everybody knows it. Now, in terms of atherosclerosis, we have to see the level of occlusion. Is it at the iliac level? Is it an iliac or at the femoropopliteal junction? Right. If you want to have a pictorial representation, I'm trying to tell you that if this is the aorta, this is the aortic bifurcation into common iliacs. These are your iliac bifurcations into internal and the external iliac occlusion. We are trying to tell you if the level of occlusion is iliac, if it is an iliac or at the femoropopliteal junction, right? It is going to be the femoropopliteal junction, right? So we will see that how the patient is going to present if they are going to have these problems, right? Now, in an iliac occlusion, right? So I'll just number them. This is as number 1, this is number 2, this is number 3, this is 1, 2, and 3. You'll be able to relate better. Now, if there's an iliac occlusion, there will be a bilateral intermittent claudication because the blood flow is going to decrease in both the vessels, right? So they decrease in both the vessels, both the limbs will have less amount of blood supply. Now, this is going to be present in the gluteus muscle, in the thigh muscle, in the calf muscle as well. Iliac and femoropopliteal will have unilateral. The gluteal sparing is seen in iliac. The thigh muscles and the calf muscles are involved. Femoropopliteal will have both gluteal and thigh sparing, only calf muscles are involved. So based upon where the patient is feeling an intermittent claudication, I will be able to get some amount of diagnosis, whether I can say the level of occlusion per se, that is it an iliac, is it an iliac, or is it at the femoropopliteal junction, right? How would you manage? For an iliac occlusion, I would go ahead with obviously the bypass is the surgery of choice. Here I would go, in terms of iliac occlusion, I will go ahead with bifemoral bypass. It is an bifemoral bypass. Here I will only go ahead with femoral bypass. Here I'll go ahead with femoral bypass. For femoropopliteal occlusion, I will go with iliopopliteal bypass. Right? The question that is asked is for femoral bypass, what is the graft used? Remember, the most common is going to be the Dacron graft. For iliopopliteal, the most common is going to be the autologous, same person's great saphenous vein. But if they ask you what is the best one, then it is going to be polytetrafluoroethylene graft. PTFE graft is a polytetrafluoroethylene graft, right? A very important aspect is whenever there is an iliac occlusion, especially in males, the blood supply to the internal iliac vessels are going to be less. Whenever there is an internal iliac supply which has been devoid on bilateral side, it will result in blood supply will decrease to the male gonads and result male impotency. So, if a patient has a bilateral intermittent claudication with male impotency, which is usually seen in iliac occlusion, this scenario you have a bilateral intermittent claudication with male impotency. This is what we call it as the Lehreich syndrome. This is what we call it as the Lehreich syndrome, right? Very, very important. Clear, guys? So this is about the occlusive status. Okay. Now, another very important topic from the NEET perspective is going to be your varicose veins. And we'll talk about the SEEP classification in varicose vein. Now, when you talk about the varicose veins, I hope everybody knows the varicose veins are defined as, they're called as or defined as distended. They're defined as distended, dilated, and elongated tortuous veins. The terms used to describe a varicose vein, these are distended, dilated, elongated, tortuous veins. Now, in a simple concept, before we move down, if I say what is the pathophysiology? What is the pathophysiology of varicose vein? It is the ambulatory venous hypertension. This is your because of ambulatory venous hypertension. Now, what is this ambulatory venous hypertension? Right? Now, to understand this, let's understand the basic concept. Now, if you take this as the representation of the lower limb, right? And let's say if this is the level of the ankle that we're talking about, this is the medial malleus, this is the lateral malleus, this is the medial side, this is the lateral side, or I can say in this simple context, right? Now, when we talk about the presentation, we all know there you have the deep venous system which is traveling here. So this is the deep venous system which is inside the muscle compartment. So if I may, I'll just show you that this happens to be the muscle compartment, and deep inside the muscle compartment you have the deep venous system, right? You have the deep venous system which is present deep inside the muscle compartment. On the medial side, you have a vein that is traveling in a subcutaneous plane or the superficial. This is your great saphenous vein, right? On the lateral side, you have another vein that is your short saphenous vein that opens at the cephalopopliteal junction. Now, together they go and empty down, right? So this I would say as the common femoral vein that is present or the deep venous system. I can resonate here by saying that this happens to be the great saphenous vein on the medial side. This is the short saphenous vein on the lateral side. And the great saphenous vein happens to be the most common vein involved in varicose vein. It is the most commonly involved vein in the, or I can say it is the most common vein involved in the varicose vein per se, right? Now, when you talk about the ambulatory venous hypertension, you need to understand that the superficial venous system and the deep venous system, they are going to communicate with each other with the help of the perforator system, and this is how you will understand the perforator system. I'll just simplify I'll just simplify the perforators as well so that you will be able to understand at a greater ease, right? Now you take this as a representation of the lower limb and it is present right across here, right? Now, for the sake of understanding, I'm going to say that this happens to be the deep venous system which is traveling all across here, right? Now take this as the representation of the superficial venous system which is communicating with the deep venous system at various levels. To be clear, we'll say this is the malleolus, right? Now you will notice that the superficial venous system and the deep venous system, they're going to communicate with each other at various levels, right? The first one is at this junction. This is called as the saphenofemoral junction or SFJ perforator. Now there is another perforator that is going to be present at the level of mid thigh, and this is what we call it as the mid thigh perforator. This is what we call it as the mid-thigh perforator, or simple words, this is what we call it as the Hunterian perforator. Another one or another perforator that is present is at the above the level of knee. Another one is below the level of knee. Now this above knee perforator, this above knee perforator is what we call it as the Dodge perforator, and the below knee perforator, the below knee perforator is what we call it as the Boyd's perforator. This is what we call it as the Boyd's perforator. Then you have another perforator which is present in the cuff. There are other perforators which are present in the cuff, and these are called as the Cocket perforator or the calf perforator. They're called as calf or the Cocket perforators, right? The calf or the Cocket perforator. Another one is present at the level of the heel, and this is what we call it as the heel perforator. This is what we call it as the heel, or also called as the May-Custer perforator. Now another very important aspect is the levels of these perforators, especially the calf perforator that you have. So we'll take the reference point as the medial malleolus. Now the uppermost that you will see will be 15 centimeter from the medial malleolus. The next one that you see across here is going to be 10 centimeter from the medial malleolus. Another one, the lowest one, is going to be 5 centimeter from the medial malleolus. So these are the levels of the perforators that are going to be present and allowing them to communicate. Now, a very important aspect is whenever we're talking about the deep venous system and the superficial venous system, now they are going to communicate with each other with the help of perforators. We have just described it. Now the question is, what is the orientation or the direction of the flow, right? Let's say this is the superficial venous system, and let's say these are the perforators which are present between the superficial and the deep venous system, right? So this happens to be the deep venous system, this happens to be superficial venous system, this happens to be the perforator system. Now, before we move down any further, a very simple question that I would like to ask you is, see, we have a central pumping unit that is heart, and every time the heart contracts, it generates pressure, and because of the pressure, the blood is pushed to every nook and corner of the body. That is understandable. How is the blood able to return back to the heart, especially from your lower limbs, and that too from a level of toe? All those are thinking that, sir, calf is going to help us. It is the gastrocnemius muscle. It is the peripheral heart. Bullshit, nonsense. It is not, right? It is an accessory mechanism. What is the status of your calf right now when you're sitting? Right now, you're listening to my lecture. What is the status? It is relaxed. If the calf is relaxed and you say that you're reliant only on calf to pump the blood back, you will die, right? It is not the calf. It is the piggyback mechanism. Remember, in the compartment, in the muscles compartment, there's a piggyback mechanism. What is a piggyback mechanism? On every artery, there's a vein that is traveling on top of it. So every time the artery pulsates, it gives a transmitting pulsation onto the vein, and this thump of the artery onto the vein will generate some amount of pressure for the blood to be pushed in forward direction. But as you can understand, if it was only reliant on that, that pressure is not enough to eject the blood into the heart. Accepted. So that is why we have the valves. What is the function of the valves? The valves are positioned in a way so that they will prevent any backward flow of the blood. They won't allow the blood to return back or fall back. They are not going to assist in flow. They will prevent the backflow. What do you mean by this? The blood that is pumped in the forward direction, when the blood tries to return back, the valve says you are not allowed because you can only go in one direction. I will prevent the retrograde flow. I will not assist in an antigrade flow. It will prevent the retrograde flow. That is why we also have valves in the perforators as well. Now, the objective of the valves in the perforators, they will allow the blood, let it be a superficial or deep system, the blood will always be pumping towards the heart, and via the perforators, they can go into the deep system and then eject into the heart. Whenever the blood tries to go from the deep to superficial, the valve says, you are not welcome, thank you, goodbye, bye-bye, you can go back and return. The blood will always flow towards the heart. in the deep system, the retrograde flow will not be allowed, right? Now, that is why a beautiful concept. Now, as the valves are present, they're assisting, right? That thumping pressure, that transmitting pulse will put the blood which is present in one particular compartment. It will push to another compartment, from there to another, from there to another, from there to another. And that is how the blood will continuously flow. It comes to the abdomen. Abdomen has positive pressure. It compresses the IVC. Thorax has the negative pressure. It pulls the blood back into the heart. Everything is done. That is why as you move away from the heart, the concentration of valves keep on increasing. IVC is valveless. I don't need valve in IVC because the abdominal pressure will exert and it will push the blood, and the thoracic pressure, which is negative, will pull the blood. It will reach back to the heart. It is the valves which are present in the lower limbs which are going to assist, right? Now, to understand the concept of varicose vein, let's take this as valve number 1. This is valve number 2, hypothetically. Valve number 3. This is valve number 4, and this is valve number 5. Between valve number 1 and valve number 2, I'll say this is compartment A, this is compartment B, this is compartment C, this is compartment D. Just for the sake of understanding, I'm just marking them as various compartments. This is compartment A, compartment B, compartment C, compartment D. Right? Now let's understand how does the varicose veins are formed. Let's say due to some reason a perforator at this particular level is broken. I'm just taking an example of a perforator. Now whenever a perforator is damaged, what will happen? The blood that is available in the deep system. Now every time it tries to go into the perforator from there to superficial, the valve says you're not allowed today, valve is broken. The blood from the deep system will now start pouring into the superficial venous system. There are two reasons. One, there's that thumping transmitting pressure that is causing the blood to flow in the deep system will now eject because of the pressure. See, the pressure in the deep system is more than the superficial venous system. The blood or fluid or liquid or gas will always flow from high pressure to low pressure. The pressure in the deep system is more, so it will flow from deep to superficial system. Now, as the blood in the superficial system is becoming more, obviously the vein which is present here, or the compartment which I have addressed as compartment A, because it has to accommodate more amount of blood, it is going to distend. It is going to distend because it is accommodating more amount of blood. Now, as it is distended, obviously the pressure in the compartment A is increased. I am not worried about the pressure in compartment A. I am more worried about the pressure that it is going to build on valve number 2. The valve number 2 is holding that blood. It is preventing from going down. But the weight, the pressure that is exerted by this column of blood on this valve number 2 will become tremendous. This valve will not break immediately because the body says I am going to hold it. But if this sustains, if not in a day, in a week, in a month, in an year, the valve will break. And when the valve breaks, it is going to give away. The minute it gives away, the blood that is present in compartment A will now go into compartment B. As the volume of blood in the compartment B will increase, the same problem will occur. What will happen? The pressure in the compartment B will increase. The compartment B will now become dilated. The pressure on valve number 3 will become tremendous. Now, because the pressure on valve number 3 is becoming tremendous, the valve number 3 will break at an earlier point when compared to valve number 2. The blood that is present in compartment A and B will now flow into compartment C. Same thing, as the pressure on the valves, or I can say the volume of blood in compartment C is increasing, obviously the compartment C will also become dilated and distended. Because of this, the volume of blood in compartment C will also increase. But there is no compartment per se, because the compartment A and B were compartment, or they were divided. They're divided in compartments only because of valve. There are no valves, there is no compartment. So I can say all these three compartments, compartment A, compartment B, compartment C, together form one single compartment. And this entire weight of this compartment is now being pulled or pushed onto the valve number 4. The valve number 4 will also break, and subsequently all these valves. As all these valves will break, you will notice the entire vein is going to become elongated, distended and tortuous, and this is what we call it as varicose vein. And this is how the varicose veins are formed, and this phenomena is called as ambulatory venous hypertension. Come back to the point, ambulatory venous hypertension. What is ambulatory? Ambulatory is moving. What is moving? The blood from the deep system is moving to superficial venous system. So what is happening? The pressure in the superficial venous system is increasing. Hypertension, ambulatory venous hypertension, causing disruption of all the subsequent valves, forming one single compartment, and that is what we call it as varicose vein, right? See, this can also happen in deep vein, but they are not evident because they are not present subcutaneously. Clear? And this is what leads to varicose vein. So now I hope you're clear in your concept that what led to varicose vein, what is this ambulatory venous hypertension, what has been this haunting. You go read in your textbook, the whole explanation is given in 3 pages. I have simplified in terms of one single diagram, and that is how you have to remember, learn and understand. I hope the concept is clear. Right? Right? Clear, guys? So this is your ambulatory venous hypertension. Now, as the varicose vein develops, they are being classified into various stages. C0, we say the patient is asymptomatic, right? The patient hasn't presented with any complaints. C1, patient will develop telangiectasia. So when we say telangiectasia, the size of the vessel is less than 1 millimeter in diameter, or it can develop into reticular vein where the size is going to be between 1 to 3 millimeters in diameter. It is going to be 1 to 3 millimeters in diameter. C2 is what we call it as the varicose vein. The criteria to call it as a varicose vein should be more than 3 millimeters in diameter. When you say C2R, that means it is recurrent varicose vein. Patient initially presented with varicose vein, he treated and he reoccurred with the varicose vein, right? Now, C3 is what we call it as. So once the varicose vein is developed, now it will start developing, because it will compress subcutaneous lymphatics, it will result in edema, and that is usually around the level of ankle. Around the level of ankle. Now, C4A is what we call it as development of pigmentation. Right? Now, this pigmentation will develop into lipodermatosclerosis, and that is 4B. And this will result into coronophlebectatica. This coronophlebectatica is also referred to as the malular flare, and that is what we call it as C4C. Pigmentation is because of hemosiderosis deposits. Lipodermatosclerosis. Lipo is fat, dermatos skin, sclerosis, fibrosis. That will result in inverted champagne glass appearance. It is an inverted champagne bottle appearance that you will see. This is also going to be present to you or referred to as the woody limb. This is also addressed as woody limb. C5 on the other hand is what we call it as a healed venous ulcer. C6 is your active venous ulcer. C6R is your recurrent venous ulcer, right? So SEEP classification has been your newfound love of your exam or the examiners, right? So these are with respect to the C in SEEP classification. E is your, when you talk about the SEEP classification, E is etiology, P pathophysiology, A is anatomical. EP stands for the primary etiology. ES, it is your secondary etiology. EN, there is no etiology found. PR is your pathophysiology. R stands for it is because of reflux of blood. O stands for it is because of obstruction to the blood flow. RO is both reflux and obstruction to the blood flow. Both reflux and obstruction to the blood flow. N, no pathophysiology that is found. In terms of anatomical status, AS stands for involvement of superficial venous system. It is involvement of superficial venous system. D stands for involvement of deep venous system. P stands for it is involvement of the perforator system. AN, no anatomical site identified. When you say what is the investigation of choice, it is going to be the duplex scan. In the duplex scan, you get this very characteristic image and this is what we call it as the Mickey Mouse sign. This is what we call it as the Mickey Mouse sign. So when you look at the Mickey Mouse sign, when you look at the Mickey Mouse sign, what do you see in the Mickey Mouse sign? In the Mickey Mouse sign, you have two big ears and a big face. Now, the big face is what we call it as the common femoral vein. This is your great saphenous vein, and this happens to be your common femoral artery, right? This is your common femoral artery, right? Okay, so this is with respect to your Mickey Mouse appearance, right? I hope everybody's clear. So far, any questions, guys? Quick feedback. So far, any questions in SEEP classification? Very, very important from the exam aspect. Clear? Can we move on? So this is the basis of your varicose vein. Okay. Yes, the Mickey Mouse sign. Common femoral vein, great saphenous vein, and common femoral artery. The common femoral artery. Okay. Sure. Now, in terms of management of varicose vein, one of the most commonly asked questions is Trendelenburg surgery. Trendelenburg surgery has three components: flush, ligate, and strip. It has three components. You have the flush, ligate, and stripping. Flushing is to empty the vein, elevate the limb, milk the vein, it goes off, right? Atrophy blanca is also present, but atrophy blanca is not a component of SEEP classification or the clinical classification. Now, when you talk about ligate, remember in Trendelenburg surgery, you have to ligate 6 tributaries, right? We have to ligate 6 tributaries of great saphenous vein before you strip it off, right? So which are the tributaries that you must ligate? And the easy way to remember is a mnemonic, that is your SEEP classification, but with 3 P's, right? In these 6 tributaries, we have 2 medial tributaries, 2 lateral tributaries, and 2 distal tributaries, right? Now, in the C stands for your circumflex iliac vein. So it is going to be superficial circumflex iliac vein. It is the superficial circumflex iliac vein, right? So C for your circumflex iliac vein. E stands for superficial inferior epigastric vein. Inferior epigastric vein, right? So here C is circumflex, E is epigastric. A stands for anterior accessory saphenous vein. It is anterior accessory saphenous vein. It is the anterior accessory saphenous vein. P stands for posterior medial vein of thigh. It is the posterior medial vein of thigh. The posterior medial vein of thigh. So here A stands for anterior accessory, P stands for posterior medial vein of thigh. Now here you have another P's that you have. One P stands for, both of them are pudendal vein. One is going to be superficial external pudendal vein. P stands for pudendal vein. Another one is going to be your deep external pudendal vein. Deep external pudendal vein. So here it is pudendal vein. Now, what is the fun? The fun is to understand which one of them is medial, lateral, and distal. Now, remember the first 2 components, the C and the E. right? The circumflex and the epigastric, these are lateral tributaries. The anterior and the posterior ones, right? These are your distal tributaries, and PP is your medial tributaries. MP, yaad rakh lo, right? Madhya Pradesh. M is your medial, PP is your medial tributaries, right? Your pudendal veins. So all these veins you have to like it in Trendelenburg surgery. When it comes down to stripping, very, very important point. Remember, below knee stripping is contraindicated. Below knee stripping is contraindicated because in below knee stripping, if you are doing a great saphenous vein stripping, it will cause damage to the saphenous nerve. And if you are doing a short saphenous vein stripping, it will cause damage to the sural nerve. It will cause damage to the sural nerve, right? Alright guys, so this is with respect to the Trendelenburg surgery. You also have the sclerotherapy. Remember the criteria of doing or performing a sclerotherapy, that the diameter of the dilated vein should be less than 3 millimeters. So sclerotherapy is ideal for perforators and recurrent varicose vein. So if there is a perforator incompetency or if there is a recurrent varicose vein, you can go with sclerotherapy. The most common agent that is used is your sodium tetradecyl sulfate. It is the sodium tetradecyl sulfate. The method that we use, it is what we call it as the Tassari's method. In that, we'll be using air and the sclerosing agent in a ratio of 4:1. That is 4 ml of air, 1 ml of sclerosing agent. So basically, in the Tassari's method, I will take 2 syringes, right? One I will load with a sclerosing agent. Let's say we have taken the sclerosing agent here. So this is the sclerosing agent that I've loaded in one of the syringe. And I will connect this with a 3-way connector or a 3-way stopper, which can be controlled from one end, right? And then I will connect another syringe here, which is going to be an empty syringe. I'm going to call it as empty because this is only filled up with air and nothing more. Now what I'll do is I will flush the syringes with each other, right? So what I'll do is I'm going to do rapid rinsing. So what will happen because of this rapid rinsing, the air from this syringe will now go from here. It will go and combine with the sclerosing agent. Now when I flush the sclerosing agent, you will notice the sclerosing agent will move down from here and then it will mix with the air. So when you do it repeatedly, after a period of time, you will notice that it will start creating foam, and this is what we call it as foam sclerotherapy. So this foam is created by rinsing the air in the sclerosing agent, and you will notice that this is now filled with air, and that air which has created a foam, and this foam is rich in sclerosing agent. Now what I will do is I will inject this foam into the vein which is dilated, right, a varicose vein. Now you can ask, sir, why don't we inject directly the sclerosing agent? One, it is in liquid form. Two, you require large quantity. Three, if it does not come in contact with the surface of the vein, it will not work. So you need to have a contact. So when I give this foam, when I inject this foam, because foam is filled with air, the minute it goes into the vein, it will expand. Now as it is going to expand, it is going to touch every nook and corner of the vein and allowing the entire vein to ablate, because this vein that you are looking across, right? This vein, when you push with the sclerosing agent, now because this foam is rich in sclerosing agent, it will come in contact with the entire surface of the vein, ablating the entire vein per se. And this is what we call it as foam sclerotherapy. Stripping is optional. It is not necessary. It is just an adjuvant. If you want to see, few patients will recommend or they want the proof that you have removed done for the vein, and that is what we do. Phlebectomy, that is, stripping is nothing but phlebectomy. You remove the vein and show it to the patient, but it is not necessary. It is optional. Bisgard's regime is done for venous ulcer. We have a standard regime that is called as 3E regime. We educate the patient about the wound care. We'll ask the patient to elevate the limb The heel should be above the level of heart. That is the allowed or the recommended level of elevating. Another E is usage of elastic compression stocking. Usage of elastic compression stocking, and that is your triple E regime. That is your triple E regime. Clear? That is your triple E regime. That's your Pisgard's regime. Clear? Educate, elevate, usage of elastic compression stockings. So this is with respect to your varicose veins. Okay. Sure. Another important topic is DVT, that is deep vein thrombosis. Remember, the most common site for DVT, it is going to be the calf veins. If they ask, if given you here, this is going to be the calf veins, the most common site for DVT. But the most common site for DVT causing pulmonary embolism, it is going to be the femoral vein DVT. It is going to be the femoral vein DVT. Now, in order to develop DVT, there has to be Virchow-Stratt. What is a Virchow-Stratt composes of? It composes of endothelial injury that can be because of trauma or sepsis or inflammation. There has to be an endothelial injury. There has to be stasis for blood flow because of prolonged immobilization and associated hypercoagulable state. And a hypercoagulable state that will result in DVT. All right. Now, if I say what is the investigation of choice for DVT, everybody knows it. The answer is going to be the duplex scan, as simple as that, right? Now, the management is going to be anticoagulation, and the regime for the anticoagulation that we use, you can use a low molecular weight heparin as well as warfarin, right? So, how do you start? On day 0, I will start both low molecular weight heparin as well as warfarin. I will continue on day 1. I will also do it on day 2, day 3 as well, and day 4. So I'll continue until the first 4 days, both low molecular weight heparin as well as warfarin. On day 5, I am going to stop the warfarin and continue on low molecular weight heparin. The day we stop the warfarin and continue on low molecular weight heparin is what we call it as the warfarin switch over time. It is what we call it as the warfarin switch over time. This is what we call it as the warfarin switch over time, right? Now, remember how long will you give the warfarin? Sorry, I've written ulta. I'm going to stop the low molecular weight heparin and continue on warfarin. The day I continue, the day from where we have stopped the low molecular weight heparin and continue only on warfarin is called as the warfarin switch over time. We're switching completely to warfarin. How long will you give the warfarin for? Remember, if it is the first episode of DVT, I am going to give warfarin for 3 months. If it is a recurrent episode of DVT, I am going to give it for lifelong. I'll give warfarin for lifelong. The target INR has to be between 2 to 3. Right? If the INR is less than 2, I'll increase the dose of warfarin. If INR is more than 3, I'll decrease the dose of warfarin. Now, when there is a DVT with contraindication for anticoagulation, one of the best examples are the recent history of stroke. Any patient who has a recent history of stroke and then develops DVT, I cannot do anticoagulation. For here, I would use an IVC filter, which is also called as a green field filter. It's a mechanical filter to filter out the thrombus, not allowing it to go to the lungs. If patient develops something called as HIT syndrome, that is heparin-induced thrombocytopenia, which is because of heparin sensitivity, right? What are you going to do? I am going to stop heparin immediately. I am going to stop heparin immediately, but I am going to switch over to. I am going to switch over to. What am I going to switch to? I am going to switch to either to fondaparinux, to rivaroxaban, or the apixaban. I can also use bivalirudin. Right? Remember, the fondaparinux, rivaroxaban, apixaban are the factor 10A inhibitors. Bivalirudin is the direct thrombin inhibitor. Your factor 10A inhibitors, these are factor 10A inhibitors. Bivalirudin is direct inhibitor of thrombin. It is the direct inhibitor of thrombin, right? So these are the essentials of your vascular component. Somebody is asking hernia कब आएगा? जब आएगा तब आएगा, सब कुछ आएगा, तो कुछ भी नहीं छूटेगा, ठीक है? So stay tuned, don't worry, we'll cover everything that is going to be important for the exam. Hernias are important. Hernias are bread and butter of the surgeons. How could I leave hernia? नहीं छोड़ेंगे, कुछ नहीं छोड़ेंगे, टेंशन नहीं, ठीक है? So this is with respect to the vascular component. Okay. So we'll do one thing. It's 8:15 on my clock. We'll take a short break here. Resume back at 8:30 so that we can do another 2 hours of session. Okay. So if you have any questions until now, you can fire it off. Any queries or any suggestions or anything that you want to interact with, I'm available. Otherwise, break it down for 15 minutes. 8:30, we'll resume back. Alright guys, so chalo, let's break it down for 15 minutes. We'll resume back. Alright guys. Alright guys, so we'll be talking about a very important topic. We'll be talking about plastic surgery. Alright, I'll just quickly wrap it up. Will you cover GIT in this session? Yes, definitely I'll be covering GIT in this session. Can we start? Can we start? Right. So in plastic surgery, one of the important ones are the grafts. We have two variants of graft. We have the partial thickness and the full thickness. Partial thickness is also called sorry is also called as a theurge. Okay. So partial thickness is also called as the theurge graft or the split skin graft SSG, and the full thickness is called as Wolfie's graft, right? The device which is used to harvest the graft is called as the Humbee's knife, which is a manual knife that you have, and an electric dermatome, which is an automated machine. Now, how do you know that you have taken the correct amount of graft in terms of partial thickness and full thickness? Because in partial thickness, we'll take the epidermis and a part of dermis. In full thickness, we'll take entire epidermis as well as dermis of the skin. How do you know that you've taken the correct amount of partial thickness? You will look at the donor site. If the donor site is associated with punctate hemorrhage, you've taken the correct thickness or split thickness, right? If the subcutaneous fat is exposed, you have taken the correct amount of full thickness graft, right? Now, in terms of donor site, let's understand the defect which is present here. It is going to be temporary. That means the skin will heal back. You can take again graft. Here it is going to be the permanent defect. There won't be any scar. This will leave the scar behind. You can take any size because I'm not worried about donor size defect. Here we will only prefer a small graft. Repeat graft can be taken because it will heal back. This cannot be done. The most common site is going to be the lateral aspect of the thigh, whereas this is going to be retroauricular, that is behind the ear. Now the graft survival is going to be good in partial thickness. It is going to be relatively poor. I'm saying it is going to be relatively poor in full thickness. The graft contracture, remember here you will have more of secondary contracture when compared to primary. Here you will have more of primary when compared to secondary. What is primary contracture? What is secondary contracture? Do you understand Marathi? Unfortunately, I don't. Thank you. So, what do you mean by a primary and a secondary contracture? Yes. See, guys, the session that I'm conducting right now should be. I'm not saying it is going to be enough, but it should help a lot in your NEET, right? So let's not get out of the focus. When it's a primary and secondary contractures, the primary contracture is the contracture that you will see as soon as you lift the graft from the donor side. Secondary is after you apply at the recipient side, right? If the contracture is more after applying at the recipient side, it is going to have cosmetically very poor outcome. Here, cosmetically, it will have good outcome. That is what you have to remember in terms of partial thickness and the full thickness graft. Now, when you talk about the causes for graft failure, the most common cause for the graft failure, it is the hematoma. And the second most common cause for the graft failure, it is going to be the seroma formation, right? Now, in order to prevent the hematoma and the seroma collection, you have to do a technique that is called as pie crusting, right? You can see in this image, the pie crusting is basically to make small holes in the graft so that the hematoma and the seroma can escape through those pores and not get accumulated, right? Guys, PDF will be given. It will be annotated. It will be the same drawings and the writings that I have will be shared. Don't worry about it. Now, when we talk about the pie crusting, what is the added advantage? Now, pie crusting will prevent the collection, but it is added advantage. It is going to increase the surface area of the graft by anywhere between 1.5 to 6 times. That means a 10 centimeter graft can be expanded to 15 all the way to 60 centimeters, right? Now, another reason for graft failure is repeated movement of graft siting that can be prevented by immobilization of joint. Infection is very important. Remember, that is why we always conduct a pre-operative wound site culture, and if there is presence of beta hemolytic streptococci, presence of beta hemolytic streptococci, it is an absolute contraindication for skin grafting. It is an absolute contraindication for skin grafting, and obviously if there is absence of periosteum of the bone, again that is a reason for graft failure. Now, cleft lip and cleft palate repair times are absolutely important. If you have a unilateral cleft lip, the usual time of repair is 5 to 6 months. Bilateral is going to be 4 to 5 months. Soft palate has to be repaired at 6 months. Hard palate is to be repaired between 15 to 18 months, right? These are the important time periods that you need to remember. If you have a patient of both cleft palate, that is both soft and hard palate is clefted, then it will require 2 surgeries. The first surgery is only for the soft palate at 6 months, and the second surgery is to repair the hard palate between 15 to 18 months. If you have a cleft lip and palate but it is unilateral, it requires 2 surgeries. In the first surgery, it is between 5 to 6 months where I would repair the lip and the soft palate. The second surgery would be for hard palate, that is between 15 to 18 months. If you have bilateral cleft lip with palate, I will require the first surgery between 4 to 5 months. As you remember, I told you bilateral cleft lip should be repaired between 4 to 5 months. Here, you will require the first surgery between 4 to 5 months period. Here, I will repair lip with soft palate. On the other hand, here we'll go with 15 to 18 months period, right? So these are again important. I hope you'll remember the time periods for this. Okay. Now, again, nutrition is a very, very important topic, right? So when we talk about the nutritions, give me 1 second, guys. Some message from the team. Oh. All right. So any questions? Okay, chalo. Now, when you talk about nutrition in surgery, again, a very, very important topic. Okay. Now, what are the indications of total parenteral nutrition? Again, a star mark point that you have to remember. One of the most common indication is going to be short bowel syndrome, and the most common cause for short bowel syndrome is going to be acute mesenteric occlusion. When we talk about acute mesenteric occlusion, one of the major reason is your SMA, superior mesenteric artery occlusion. It is going to be the SMA occlusion or the superior mesenteric artery occlusion, right? Another one is high output enterocutaneous fistula. It is considered a high output if it is more than 500 ml of output in 24 hours. If there is presence of acute active inflammatory bowel disease, if there is an initial phase of acute pancreatitis and a prolonged IES of more than 72 hours. I hope everybody knows the criteria for small bowel syndrome. We call it a short bowel if the length of the small intestine is less than 200 centimeters. If the length of the small intestine is less than 200 centimeters, right? Now, when you talk about the composition in terms of TPN, again, very important. Carbohydrate consists of maximum amount in terms of percentage. 40 to 50% of total volume is your carbohydrates. It releases 3.5 kilocalories per gram. This is the energy that is released. Fat consists of the next most important one, that is 30 to 40%, and it releases 9 kilocalories per gram. Protein is consists of 10 to 20%. It releases 4 kilocalories per gram, and these are in trace quantities, right? That means they are in a very limited or a minimum quantity, that is your minerals and vitamins or trace elements do not contribute for any energy release. In your previous exam, they've asked you how much energy is the carbohydrate, fat and protein produces, and you have to calculate the total energy release based upon this quantity. Clear? Now, when we talk about the complication associated in total parenteral nutrition, tube related, remember the most common is going to be line sepsis, right? It's not tube related, it's line related, right? So make a small correction here. This is not tube related. This is going to be line related, right? So this is going to be line sepsis. The most common is line sepsis, right? But apart from that, it can result in pneumothorax. It can result in thoracic duct injury. It can result in pneumothorax. It can result in thoracic duct injury. It can also be associated with cardiac tamponade. It is also associated with cardiac tamponade and other issues as well. Feeding related is your refeeding syndrome. Refeeding syndrome because of rapid increase in sugar. When you give carbohydrates, initially the patient was starving, the low sugar, low insulin. Sudden increase in carbohydrates will cause sudden increase in sugar. In response to that sudden increase in insulin. Now, when there is the insulin drive increases, it activates the sodium potassium pump or the sodium potassium ATPase pump, which drives the potassium back into the cells. The potassium will drop. Along with that, it will also have a significant effect on the magnesium and the phosphate. It will result in severe drop in magnesium and phosphate along with thiamine deficiencies. All these put together is called as refeeding syndrome. And remember, refeeding syndrome is a life-threatening complication. So refeeding syndrome is preventable. So for this, you have to give low osmolar TPN. You have to give small quantity of TPN and increase gradually, of course, right? So this is how you can prevent the refeeding syndrome. This is how you can prevent the refeeding syndrome, right? So that is all with respect to your, I would say, the nutrition concept or topic per se. Now, another important topic is hernia, and one of the important is your classification that been asked across. One of the important classification is going to be the NEET classification of hernia, right? Now, we have various different classifications. I don't want to get into the greater components here, but we'll try to address which are important, right? NEET type 1. Remember what I'm going to underline. In type 1, it is the indirect inguinal hernia, right, with a normal ring. Type 2, it is the indirect hernia with an enlarged internal ring, right? Type 3A, it is a direct hernia with the posterior floor defect only. Type 3B, it is an indirect hernia with enlarged ring and posterior floor defect also. It can result in both direct and indirect, that's Pantaloons hernia. 3C is your femoral hernia. 4 is either a recurrent hernia, A direct, B indirect, and C femoral, or D combination of both ABCs, right? This is your type 4. But remember, type 4 is in turns remembered as recurrent hernias, right? So far so good, guys. Any questions? Quick feedback. Now, one of the important aspects that I would like to bring across is about the laparoscopic inguinal hernias. Now, in the laparoscopic inguinal hernia, one of the most important aspect is the triangle of doom and the triangle of pain, right? We've been talking about it, we've been understanding it. So let's understand. I've given you an annotated image, but I'll make it very simple for you. What is the triangle of doom and what is the triangle of pain, right? So we're talking about the triangle of doom here. So when you look at the abdominal wall, let's say if this is the abdominal wall, what I'm drawing is the outermost, that is the skin, right? Then let's say this is the subcutaneous fat that is present. This happens to be the muscular component of the abdominal wall, and we will take this as the midline. This is the midline, and I will say this is the peritoneum that is present through and through. This is the peritoneal cover that is present, right? Now, when you do an internal hernias, I'm going to dissect this peritoneum and I'm going to bring it down. So I will create an opening in the peritoneum, and the peritoneum is laid open, and we are inside the peritoneal cavity. We have gone inside the peritoneum. On the medial side, you will see there is a small opening that is present, that is called as the deep inguinal ring or the internal ring. In this component, you will see there is a structure that is traveling from the superficial inguinal ring. If I contribute across here, I will say that this is the superficial inguinal ring, this is the deep inguinal ring. You will see from the scrotum, you see from the scrotum, there is this vast difference that is coming. It travels through the inguinal canal. It comes here and then turns medially. That is your vast difference. Laterally, you will see there is this gonadal vessel that is going to go across here, right? Now, if you see the area that is present, the area that is present between, short of colors, okay, the area that is present between the deep inguinal ring, the gonadal vessel, the peritoneal reflection, and the vast difference, this is what we call it as the triangle of doom, right? So the triangle of doom, we call it as doom because you have the iliac vessels which are present here, both the iliac vein as well as the iliac artery, right? Both the iliac vein as well as the iliac artery are present in this particular status, right? Now, when you look at the component in terms of it, this is the medial boundary. This happens to be the lateral boundary. This is the inferior reflection, and this happens to be the superior boundary. Okay. Now, medially it is guarded by vast difference. Laterally it is guarded by gonadal vessels. Superiorly by deep inguinal ring. Inferiorly by the peritoneal reflection. Inferiorly it is formed by the peritoneal reflection. Right. Now, what are the content of the triangle of doom? The content of the triangle of doom is the external iliac artery. It is the external iliac artery and the external iliac vein. So injury in this region will result in a torrential hemorrhage, and hence it is called as the triangle of doom. Same way you have the triangle of pain, which I have described it here. Now all that you have to understand is, if we give in the same context, this now in triangle of pain, when you look across here, okay. Again, this happens to be the skin, or I can say in terms of presentation, outermost. This is the subcutaneous plane. Let's say this is the abdominal wall muscles that you have, and let's say this is the peritoneal reflection that you have brought down. Right in the middle, you have, when you talk about the midline, obviously you have the pubic bone and the pubic tubercle. So I'm just taking this as the mid bone. This will take as a deep inguinal ring. We told you that there is a vast difference that is traveling here. There's a gonadal vessel that is traveling here, right? Now, this area is what we call it as the iliopubic tract. Now, between, this is the lateral side. Now, this becomes the lateral boundary. This becomes the medial boundary. This becomes the inferior boundary. And this is your deep inguinal ring, that is the apex. Medially, it is now formed by vast difference. Inferiorly by peritoneal reflection. Laterally by iliopubic tract. Now this consists of various nerves, right? The nerves which are going to be present here, that are going to be in terms of the femoral nerve. You have a nerve that is traveling across it, that is the femoral nerve. The genital branch of genitofemoral nerve, right? Then you have the lateral cutaneous nerve of thigh, right? So if you look across it, this happens to be the femoral nerve. This is the genital branch of genitofemoral nerve, and this is the lateral cutaneous nerve of thigh, and this happens to be, this is the most common nerve damage in laparoscopic inguinal hernia repair. In laparoscopic inguinal hernia repair. In a laparoscopic inguinal hernia repair. Right? So this is going to be the triangle of pain. So when you look at in this particular context, you can see this is the deep inguinal ring that is present here. This is your deep inguinal ring, also internal ring. This is the vas deferens. This is the testicular vein and the artery that is gonadal vessels. This is, you can see, the external iliac vein and the external iliac artery will run across here. This is your triangle of doom. Same with the triangle of pain. Now there is another variant that you have which is called as the corona mortis. The corona mortis is also called as the crown of death. This is also called as the crown of death. Now in the crown of death, this is an aberrant anastomosis between the inferior epigastric artery, and the obturator artery. That is what you have to remember. Right? Now we call it as corona mortis because this abnormal connection, it is going to lie very close to pubic tubercle. It lie very close to pubic tubercle. Now because it is going to lie very close to the pubic tubercle, and when you are fixing the mesh to the pubic tubercle with a tacker, right, that is going to cause a puncture in this vessel which will bleed very profusely. Right? Okay. Clear, guys? Clear? Chalo. Yeah, guys. So these are with respect to hernias. Now let's go on to a rapid mode on GIT X-rays, or the GIT imaging, which are going to be asked on very common context. In the first one, we have the esophageal. We have this image, which is of barium swallow, right? So on a barium swallow, what do you think is abnormal across here? I would want you to focus at this particular site, and you will see that this is where there is. If you take this as the esophagus, this is the cricopharyngeal region. You can see the cervical region. You see there is this nice diverticulum or the outpouching, and the barium continues to flow. And this is your pouch esophagus. That is, our esophagus is forming a pouch. And this is what we call it as, I hope everybody knows it, that is the Zenker's diverticulum. This is what we call it as the Zenker's diverticulum, right? Now, when we talk in terms of Zenker's diverticulum, I hope everybody knows it is a false diverticulum. This is your false diverticulum, very, very important, right? The anatomical weakness, that you will see in Zenker's diverticulum is via the Killian's triangle. Now, Killian's triangle is basically between the cricopharyngeus and the thyropharyngeus muscle. It is a cricopharyngeus muscle and the thyropharyngeus muscle, right? It is going to be on the posterolateral side. It is going to be the posterolateral side. Majority of them that you will see will be present on the right side. This is left sided, right? If you have the mid esophageal or parabronchial or the epiphrenic diverticulums in the esophagus, they are right sided. This is left sided. If I say what is the best treatment or the gold standard treatment, this is going to be diverticulectomy. This has to be diverticulectomy, right? You can also do diverticulopexy with the lateral pharyngeal wall or the prevertebral fissure, but diverticulectomy is considered to be best. You would see there is a surgery that is called as the Dolman's surgery. this is only done if the size of the diverticulum is greater than 3 centimeters. If the size of the diverticulum or the opening mouth is less than 3 centimeters, you will not be able to apply an endo-GI stapler in this. That cannot be performed, right? Okay. Now, if I give you this X-ray, these are the 3 sets of X-ray that I will give you. This is a neonate, a newborn. So the data that I'll give you is a newborn, right? This is probably taken on day 0 or day 1 of life. There is repeated regurgitation. There is repeated regurgitation of all feeds. There is repeated regurgitation of all feeds that you will notice, and there is continuous drooling of saliva. There is continuous drooling of saliva that is present. There is regurgitation of all feeds and continuous drooling of saliva. It cannot be CHPS, because somebody is saying CHPS. Remember, CHPS will be seen at 1 month of life, not on day 1. Right? Hypertrophic pyloric stenosis is seen, or conjoined hypertrophic pyloric stenosis, at 1 month of age, not on day 0, day 1. You have repeated regurgitation with continuous drooling of saliva. That goes in favor of tracheoesophageal fistula, right? And obviously with esophageal atresia, right? When you can see here in this particular X-ray, I can see the Ryle's tube is occluded and there's a massive fundus gas shadow. That means that the air that is going into the trachea, from there it is entering into the esophagus, from there it is going into the stomach and air getting trapped. So massive air bubble and stucking of your Ryle's tube. Or when you see in this image, there is coiling of the nasogastric tube, or there is occlusion, or there is stop at the red rubber catheter. It is going to be your tracheoesophageal fistula or atresia, right? So this is where you have the coiling of the nasogastric tube. Coiling of the nasogastric tube is an indication of tracheoesophageal fistula. I hope everybody knows the most common type. It is called as the type C variety or the type 3 variety, right? In the type C variety, I hope everybody knows it. It is going to be the proximal atresia with distal communication. You see, if this is the representation of the trachea, the trachea remains absolutely fine. There is no problem. The upper segment of the esophagus will have an atresia, and the lower segment will be communicating with the trachea along with the esophagus, right? And this is what we call it as the tracheoesophageal fistula. That is the type C variety. That is going to be the type C variety. Yep. So another one is this X-ray. Can you spot? I've given you a marker also. This is your upper esophageal web. This is your upper esophageal web. Now the upper esophageal web, it is seen in a condition that is called as the Plummer-Vinson syndrome, or also called as, this is the alternate name, or also known as Patterson-Kelly syndrome. Also known as the Patterson-Kelly syndrome, right? Now, when you look across here, this is what we call it as the lower esophageal web. Now, the lower esophageal web, also popularly or commonly referred to as the Schatzki's ring. It is also called as the Schatzki's ring, and the Schatzki's ring that you see across here, right? The Schatzki's ring that you see, it is your lower esophageal web. There is a lower esophageal web, which could be a sequelae or it could be secondary to GERD as well. It can be secondary to GERD as well. Now remember, when you talk about Schatzki's ring, it is going to be a concentric and it is going to be uniform, right? It's a symmetrical mucosal thickening. It is going to be a symmetrical mucosal ring that you see here. Whereas the upper esophageal web that you have, it is asymmetrical. It is asymmetrical. That is how you will recognize. Right? I hope everybody is clear. Now, if you see in this patient, where the patient presents to you with dysphagia, and whenever I talk about dysphagia, three important questions that I always ask you to ask your patients to get a conclusive diagnosis. Is the dysphagia for solids, liquids, or both? The dysphagia is for both solids as well as liquids. Is dysphagia more for solids or more for liquids? Here, dysphagia is more for liquids when compared to solids. Is it going to be a progressive or a non-progressive dysphagia? This is a progressive dysphagia. Usually seen in females, right? Now, you have dysphagia, which is for both solids and liquids. Dysphagia is more for liquids when compared to solids, and it is progressive in nature. And on a barium swallow, you see this. This is a very characteristic, right? You can see a very characteristic narrowing that you see, like a beak. And if I just draw an eye, it looks like a bird, right? This is your characteristic bird beak appearance. This is also referred to as the pencil tip appearance, or also referred to as the rat tail appearance. All these points towards your achalasia cardia. It points towards your achalasia cardia, right? Now, for achalasia cardia, the investigation of choice will remain as manometry. Remember, for all motility disorders, it is manometry alone. Right now, when you talk about the surgery of choice for achalasia cardia, it is going to be the Heller's myotomy. It is going to be Heller's myotomy. Right. So, sorry. Right. Again, this time we have a patient who has presented with severe chest pain. Along with severe chest pain, the patient is having dysphagia. Here, dysphagia is for both solids and liquids. The dysphagia is equally present for both solids as well as liquids, and this is non-progressive dysphagia. This is a non-progressive dysphagia. Now, on barium swallow, you see the barium is misbehaving, and you see it is going like a coiled loop, right? You can see here also it is going like a coiled loop, and this is what we call it as the cork screw appearance. It is also referred to as the pseudo diverticulum appearance. This is also called as pseudo diverticulum appearance. This is also referred to as rosary bed appearance. This is also referred to as the rosary bed appearance, or also referred to as the beaded appearance, right? All these points towards diffuse esophageal spasm. DA stands for diffuse esophageal spasm, which is a classical for corkscrew appearance, right? So the single best answer is going to be corkscrew appearance. Okay. Now, We have already spoken about the Schatzki's ring, which can be seen in the patients of GERD, right? The Schatzki's ring is an important component of the GERD, but along with this, if you have this component with this, you can see the part of the stomach is moving into the thoracic cavity. This is classical for the hernia, right? If you see a part of the stomach which is invaginating into the thoracic cavity, this is what we call it as the rolling hiatal hernia. On the other hand, you see the gastroesophageal junction, which is drifting above the level of the esophagus with the Schatzki's ring. This is what we call it as the sliding hiatal hernia. This is your sliding hiatal hernia. The rolling hiatal hernia and the sliding hiatal hernia, right? So these are the X-rays of sliding hiatal hernia as well as the rolling hiatal hernia. Another one, a very characteristic that you can see, a retrocardiac air fluid level, right? That is seen in a sliding hiatal hernia where you can see it is going behind it. So you can observe this which is present. This is your retrocardiac. This is your retrocardiac air fluid level. This is a retrocardiac. You can see it's here. It is the retrocardiac air fluid level, right? And this retrocardiac air fluid level is also seen in your sliding hiatal hernia. In the sliding hiatal hernia, you can see the doubling of the esophagus, and this is what we call it as the double barrel esophagus. The double barrel esophagus can be seen in two different components. One you can see in dissecting aneurysms. Another one, it can also be seen in mucosal dissection of esophagus. In the mucosal dissection of esophagus. On the mucosal dissection of the esophagus, right? That's a double barrel esophagus. Right? This is what we call it as, you can see this is, you can see these lines, stripes, rings are formed. This is what we call it as the feline esophagus. We call it as the feline esophagus, or also called as the stacked mucosal rings. Also called as stacked mucosal rings. These are seen in eosinophilic esophagitis. They're seen in eosinophilic esophagitis. They're seen in eosinophilic esophagitis. If you have an X-ray which is presented to you like this, right, what are you looking at? One second, guys. It's misbehaving for a minute. Right, when you see an X-ray which has been pointed like this, this indicates presence of foreign body, right? So this is the foreign body X-ray. Now the problem with this foreign body is obviously in the esophagus. Foreign body in esophagus, right? Now, how do you differentiate whether it is a button or is it a battery, right? How do you know if it is a button battery or if it is a coin, basically, right? Now, if it is a coin, right, the battery will give you a double ring sign, the coin will give you a single ring sign. Now, if you see very carefully here, you can notice it will have an inner ring and there is an outer ring. If there is a double ring appearance, this is a battery. We call it as the button battery. If it is a single ring appearance, this is a coin, right? This is going to be a coin. A double ring is button battery, a single ring is going to be a coin. If you see now, you'll be able to understand much better, right? So button battery will have a double ring. This is going to have basically a single ring. Right. So now, if you have a baby who is 4 weeks old with gastric outlet obstruction, right, and there is presence of visible peristalsis and the abdomen is like this, you can see there is a nice bowing here and there's a nice lump which is present. This is what we call it as the olive lump presentation. This is what we call it as the olive lump presentation, and this is what we call it as the scaphoid, that is boat shaped abdomen. This is what we call it as the scaphoid abdomen, the boat shaped or the scaphoid abdomen. Guys, 1 second, I just need to recon the calibration. It is every time we're trying to write, it is just skipping. I'll just recalibrate. Give me 1 second. It's going to be a very short break. All right, guys. One second, guys. It is misbehaving again. Just give me a second. Yes. So the diagnosis for this case, as majority of you have rightly said, it is going to be congenital hypertrophic pyloric stenosis. That is a CHPS, right? Very good. Now, the criteria for CHPS, one of the important aspects is the investigation of choice. That is going to be ultrasound. Ultrasound will present to you with a double track sign or the double track appearance. Now, the characteristic of this track that we have to understand, it is the length of the tract. It should be a minimum of 16 millimeters, and the width of the tract should be a minimum of 4 millimeters, right? A 16 and a 4 millimeter that you need to be assessed across, right? Now that is an important aspect, right? It can also have a presentation of a caterpillar sign that you can see here. The caterpillar sign, right? You can see here. It's a caterpillar sign, right? That's the caterpillar crawling. The surgery of choice for CHPS is going to be Ramsted's pyloramyotomy. Now, this is the most frequently asked X-ray. You can see this happens to be the diaphragm. I'll just label it for you. This is the liver surface. And this is the free gas. That is the free gas under right-sided diaphragm, right? This is the free gas under right diaphragm. You can see here the diaphragm is continuous and some mode of air is also there. If there is a free gas under right hemi diaphragm, this is consistent with the hollow viscous perforation. This is consistent with the hollow viscous perforation, right? The other signs that you will see in a hollow viscous perforation or this free gas in diaphragm is also called as the Regler's sign. This is also called as the Regler's sign, right? Now, when we say, okay, sorry, Regler's sign, this is the free gas and Regler's sign, I'll explain you across. The free gas and diaphragm is the consistent sign for hollow viscous perforation. When we see the Regler's sign, you will see the illuminated bowel loops, right? You will be able to see this surface, right? This marking of the bowel loop, if you are able to see, because inside there is air, outside there is air, and in between two air surfaces, you have the bowel loop, that is Regler's sign. If it becomes entirely distended, we call it as the dome sign or also called as the football sign. Also called as the football sign, right? Now, similar sounding component that you will see across here is what we call it as the Regler's triad. This is your exams question, right? What is your Regler's triad, right? So, when we talk about Regler's triad, here the patient will present to you with a small bowel obstruction, The patient will present to you with small bowel obstruction. There will be presence of pneumobilia, air in the biliary system, that is pneumobilia. Along with pneumobilia, you will have, there is ectopic gallstones. Now, the cause for Riglerstrad, it is basically because of bilioenteric fistula. It is the bilioenteric fistula. The most common site for the bilioenteric fistula, it is your cholecystoduodenal fistula. It is the cholecystoduodenal fistula. Here you can see there is one bubble here, another bubble here. This is what we call it as the double bubble sign. This is what we call it as the double bubble sign. Double bubble sign is seen in duodenal atresia. This is what we call it as duodenal atresia. Okay. In here, I hope you are able to see this fecalith, or I can say this stone-like presentation. That is going to be your ectopic gallstones. So the C here indicates pneumobilia. This is your obstructed bowel, and that is your fecalith, or I can say ectopic gallstones. Clear? Now, when you say in terms of again a variant of your double bubble sign that you have, one is the fundus gas shadow in the stomach, another one is the duodenal gas, right? Double bubble sign again, right? This is what we call it as the corkscrew appearance on an intestine. This indicates malrotation. Corkscrew appearance of intestine. This is seen in malrotation of gut. It is seen in the malrotation of the gut. You have a CT image. In the CT image, you can see it is like this. This is what we call it as the whirlpool sign. The whirlpool sign is seen in mid-gut volvulus. It is seen in mid-gut volvulus, right? Now, the last X-rays that I would like to discuss, how do you differentiate between a small bowel obstruction and a large bowel obstruction? This is your small bowel obstruction. This is your large bowel obstruction. In a small bowel obstruction, you see multiple air fluid levels which are more than 3 to 5. These are your multiple air fluid levels. These are your multiple air fluid levels which you can see across here, right? On the other hand, you see massive colonic distension or the transverse colon that you see in a large bowel obstruction. Remember, large bowel obstructions are surgical emergency, right? So these are the important radiographs in the GIT and the topics that you have to look across, right? So I try to cover in a comprehensive way whatever is required for the present exam for this March that you're going to attempt, right? So a couple of important tips and advices that I would like to give. Repeat, revise, whatever you have read. Do your 5 years of question bank. Do your last 5 sessions of your Central Institute exams, and that should be able to do enough, right? So these are very, very important aspects that you cannot ignore. All that we have done in the rapid revision series that we have done in the sprint, it is all about the high yield topics. Yes, the concepts are much more deeper and the presenting factors are also very important. Because of the time constraint, we have tried to do it as much as possible. I will be seeing you guys very frequently on the YouTube sessions with respect to our PW Med ed that we are going to look across. A sprint is just a push for all of you. We'll stay in touch. If you have any questions, I'm here for you. Otherwise, signing off for the session. Thank you guys. So if you have any questions, fire it away. Or else, thank you. Good night. Prepare well, read well. See you guys again. All right. Thank you guys. Have a good night. Thank you.